Good morning, everyone. Welcome to the Special Olympics Alaska Jim Ballamacy Training Center. My name is Sarah Artz. I am the CEO for Special Olympics Alaska, and I'm very honored to be the host venue for this event. I want to start today by just going through a few housekeeping things. The bathrooms, if you haven't found them already, will be right over here in between the middle of the gym. There's additional bathrooms towards the exit on the far corner of the gym, and also restrooms upstairs on the track. If needed, there is an AED machine in the building. It is located over by the check-in in the registration area. And then we also have emergency exits throughout the building. So now to the fun stuff. Welcome to the 11th Annual Disability and Aging Summit. World all across the United States, and we're very excited to have you join us, so welcome online. Today we are very excited to kick off our two-day summit and talk about bridging the gap between all of the different agencies represented here today when it comes to caring for our individuals with intellectual disabilities as they age. So just a special shout out to all of the vendors in the room upstairs on the track. Please make sure during the vendor time that you take the opportunity to go and look at all of the amazing resources that those organizations have to offer. Also, make sure to have time to collaborate with each other. Some of our most powerful connections are made just by talking to your colleagues. So please take time to chat with each other. Today we have our keynote address, followed by our Honoring Connection presentation, palliative care for people with disabilities. Then we'll have lunch on your own. We will have food truck on site, but there's also some really great restaurants really close to here. There's a great hamburger spot just down the road. There's also Hollows right down the road and some fast food places down the street. When we come back from our lunch break, we've got creative rhythms, fraud prevention and awareness, and followed by our closing remarks. And then tomorrow, we are very excited to have our emergency preparedness, and then we have our different panels, our panel on advocacy and our panel with planning and safety, and then we also have legislative advocacy workshop, assistive technology and aging with autonomy, and then a recognition of our trailblazers. I just wanted to take another quick second just to recognize our coalition members. A team of people from a variety of organizations plan this event every year. We have Emily Vandergaan from Special Olympics Alaska, who is our inclusive health manager, that you can ask questions. Ricky, I believe, is at the back at the registration table with Brenda. Michelle is here as well. Ian, unfortunately, has jury duty, so he was here this morning. Thank you, Ian, for setting up the breakfast, and he hopes to be back when he's done with his jury duty. Yasmin, Joe, one of our athlete representatives on the coalition, Stephanie, who's, I believe, here somewhere. Lanny is also here. Thank you, Lanny. Patty. Patty's here, one of our, I know she's here. So, there she is. Thank you, Patty. Karen is also here today, and Richard and Lisa. So if you see those guys, please thank them for their time in planning this event. We'd also like to say a special thank you to our sponsors, Alaska Regional Hospital, the Alaska Mental Health Trust Authority, the Governor's Council on Disabilities and Special Education, UAA Center for Human Development, the Alaska Training Cooperative, and then all of the vendors we'll go through later today. So thank you very much. Now it is my great pleasure to introduce our keynote speaker, Dr. Jonathan Santoro. Dr. Santoro is a nationally recognized pediatric neurologist and physician scientist whose work is transforming the way we understand and treat neuroinflammatory and neurodevelopmental disorders. He currently serves as the Director of Neuroimmunology and Eliminating Diseases at Children's Hospital Los Angeles, and as an Associate Professor of Neurology at the Keck School of Medicine at the University of Southern California. Dr. Santoro's clinical and research interests focus on improving outcomes for children and adults with complex neurological conditions, including those with intellectual and developmental disabilities. He has published extensively, contributed to advancing inclusive medical care for individuals across the lifespan, and is deeply committed to bridging the gap between pediatric and adult neurological care as individuals age. Dr. Santoro is perhaps best known for his groundbreaking research on Down syndrome regression disorder, a rare and complex neurological condition that can cause sudden loss of skills and abilities in individuals with Down syndrome. His pioneering work has helped uncover new insights into the underlying causes of this disorder and has led to more effective, evidence-based treatment approaches that are changing lives around the world. Beyond his research, Dr. Santoro is a passionate advocate for inclusive, person-centered healthcare for individuals with intellectual and developmental disabilities across the lifespan. His work exemplifies compassion, innovation, and a deep commitment to improving quality of life for those he serves. Please join me in welcoming to the stage Dr. Jonathan Santoro. And he's a walker, so I'm going to bring him the mic.
All right, thank you, Sarah, and thank you everybody for having me up to Alaska. This is a fantastic privilege as we put some mood lighting on, apparently. You know, normally somebody like me who's a very specific subspecialist, I love talking about things that are very narrow, right? So things like Down syndrome regression disorder is something that only affects 1 to 2% of people with Down syndrome. But today I'm going to go a little bit more broad. So obviously my focus and passion is people with Down syndrome, but really as a neurologist I work with people who have autism spectrum disorder, other types of intellectual disabilities, other types of neurogenetic conditions. And I think that really as we think about how do we care for people when they make that jump in transition from being a child to an adult and then to an older adult, I think there's a lot of cool things that we can use. Oh, I have to get away from this speaker apparently. So, you know, the big piece is how do we kind of have that transition, and what do we need to know as caregivers, as you know, people who are assisting in other environments. So I've tried to keep it very broad, make it tip-based, and I've left tons of time at the end to answer any questions that the audience has, because I feel like that's often where the best discussion topics come from. So with that, I will do a brief introduction. We'll talk about ways to work with people with intellectual disabilities. This is something that nobody gets really training on in many different environments. But I think that there are some very basic tips that actually really help because we use them in pediatrics so much that it actually can carry over to adult, treatment plans as well. In addition, we'll talk about normal aging in Down syndrome and others with intellectual disability. And then also common neurologic diseases that exist in people who have normal aging in these other conditions as well. Because I think that knowing what those are, you can actually have a little bit of a forward-thinking approach to see what are the things that I should also be looking for in addition to the normal aging process. And then finally, we'll talk about when to ask for help. I think that it's probably no surprise to you. In Alaska, there's not a lot of specialists, as it turns out. And I think that sometimes the caregivers are the first line of defense to say that something is wrong, something is different about my client's case or my patient's case. I'm going to actually speak up and be the person that initiates this process. So the first component of this is just kind of working with people with intellectual disability. And I think that this is one of those things where, people with Down syndrome, people with intellectual disability, they may look different, they may talk different, but it is the most rewarding experience to work with these individuals. There is unbridled love, and it's there's a reason everybody is in this room and on this Zoom call today, because we like working with these patients. And I think that this can be something where there's often a lot of fear. Sometimes in neurology we call it neurophobia. People are afraid of things that are different or complex. But I think that the hopes of this presentation is that we can lower down some of those barriers to actually get people to engage with this population as well. When we talk about disability, disability can be many, many different things. I think that when we often think about it, the first two are the most common that we think of. When somebody says somebody is disabled, our mind immediately goes to, okay, are they cognitively disabled or are they physically disabled? And I think that, for the most part, these don't have to be mutually exclusive. You can have both at the same time. These are conditions like cerebral palsy, where you can have a motor impairment or a stiffness of the muscles plus a cognitive impairment in some patients. Language and speech is another one that doesn't actually get attention a lot. It often gets lumped into cognitive. But in individuals who are older who have had a stroke, let's say, they may be totally cognitively intact, but they can't actually get the words out. That's something called an aphasia in neurology. So this is something where when we're communicating, just on a day-to-day basis, if we ask a question and somebody can't answer us back, it's very difficult for us. We want to know. But that receptive language or the ability to understand what's going on may be totally normal in that individual. So we have to think of other ways to communicate with people who have that special type of disability. Sensory disability. So these are individuals, see, I'm getting too close to this speaker again. Sensory disability is when your hearing or vision is impaired. This is very common, not just in people with intellectual disability and Down syndrome, but the general population. I mean, how many people know somebody who has a hearing aid? I mean, pretty much everybody in the room, right? So these are things where it's very common, but it is a form of disability because you have to make adaptations to your day-to-day process to actually accommodate for it. And then finally, the last, silent disability. There are some people that you look at and they look totally fine. They speak totally normally. They would, you would never guess that they have a cognitive impairment. This happens a lot in individuals who have conditions like multiple sclerosis, where you can't necessarily see what's going on under the surface, but there may be pretty significant impairments to their day-to-day function from there.
Would FAS fall under that?
Sorry?
FAS would fall.
Yeah, so the question was, does FAS fall under that? Yes, so FAS would actually fall under several of these. But yeah, I mean, if you take any one condition, you could probably say, oh yeah, you know what? 3 of these 5 actually fit. When we talk about what causes disability, this is a really important thing for me as a neurologist. My job is to figure out what is actually causing this person to be disabled, to have one of those 5. And so this diagram on the far right here is really more specific to people who have cerebral palsy. But in the brain, when you have an injury, you can have a specific pattern of illness that goes along with it. You may be weak on one side. You may have stiffness on one side. Again, you may have the inability to speak. And so brain and spine conditions are obviously what neurologists focus on, but really anything can cause some disability. I had a question right up front. You have cerebral palsy. So when we think about it, right, the cause of cerebral palsy can be different in individuals, but the pattern of disease may be shared across that. So again, as the neurologist, I'm trying to say, all right, I think that this is probably the cause for their cerebral palsy, and then we focus on the treatment of those specific symptoms. When we're talking about disability, though, it's important to know the lingo. Doctors love using lingo, in case you haven't noticed. And so I think that finding ways and cross-terminology to make sure that we're talking about the same thing are really important. So when we're talking about people who have physical disability, again, this falls under the cerebral palsy branch of things, we see that spasticity gets talked about a lot. And this is a tightness of the muscles or a rigidity. An example of that is up top over here. Let me see if I get my little pointer going, where you can see that individuals who have this will often keep their upper arms close to their chest. You can see this when they're walking because that arm gets very stiff. You'll see that the arm, or the forearm rather, is pronated. So when somebody has high spasticity, they often will hold their arm into their chest like that. And some of these more subtle findings on the bottom are what people actually do with their hands. In the upper extremities, or the arms, these are things where everything kind of gets tight. So if you flexed all of your muscles at once, right? You flex your bicep, you flex your wrist, you flex your fingers in, they're all going to end up doing this. So it's actually something that is relatively easy to pick up, even for somebody who's not a neurologist, to see that pattern that could be indicative of either a brain injury or cerebral palsy. Hypotonia is the opposite of that. The muscles are very loose. People with Down syndrome, for instance, have hypotonia from the moment that they're born. These are people where the muscles are the opposite. They're floppy, they're a little bit less resistance when you're pushing muscles against it. Both spasticity and hypotonia don't have to do with strength. You can be totally strong. I think Special Olympics is a great example of that. So you have people with cerebral palsy and Down syndrome who achieve remarkable things physically because strength isn't dependent on what that tone is in people. The three other pieces here, so ataxia is an unsteadiness, and the best way that I can, describe this is it looks like somebody has had a few drinks where they can maybe a little bit more wobbly. Ataxia localizes to a part of the brain called your cerebellum. So there are many conditions, Down syndrome being one of them, where that area of the brain can be formed a little bit differently. And so balance can be an issue for those individuals, and falls can happen in people who have an ataxia. The fourth one, dyskinesia, this is where you have extra movement that's not under your own volition. So sometimes this is little jerks like that. Sometimes it's a little bit more of a writhing behavior, but these are extra movements that you would be able to pick up on. These are the common terms that get utilized when we're describing what that type of physical disability is. None of them are good or bad. They're not prognostically significant. But when you have a client or you have a patient that has one of these things, it allows you to actually communicate with the medical team very clearly. If you can say, look, Mr. Smith has really bad spasticity. We know this, but it seems to be getting worse because he's holding his arm tighter to his chest and he's complaining of pain in his hands now, right? So just in using that same terminology, the neurologist or the family practice doctor knows exactly what you're talking about. So that's why knowing, I think that when we're talking about intelligence, there's so many different components of it. For how we describe disability, though, there's intellectual disability, which is most commonly ascribed to IQ. And again, this is an imperfect measure that was made almost 100 years ago now, and it's just kind of fallen by the wayside in terms of how we use it, but it is still something to know about. Learning disabilities are very specific. You can have individuals, often in childhood, who have specific types of problems learning math, or have specific problems with reading and writing, like dyslexia. These are things that, as we're able to describe it more in childhood over the last 2 decades, adults will carry on these diagnoses. These are really important to know about because if, for instance, you have an activity at your care center that is reading focused and you have a patient with dyslexia, it may be extra challenging for you. So knowing that type of terminology can actually help you adapt programs moving forward. Autism spectrum disorder, again, another hot topic over the last 20 years, is diagnosed but has a broad spectrum. And that's why I call it a spectrum disorder, is there's patients on one end of the spectrum who can speak very fluently, can work jobs, and do all of the things that we would want them to do. On the other end of the spectrum, we have individuals that may not be able to communicate at all, may be entirely dependent on their caregivers or loved ones for self-care. We also have memory and cognitive impairment. We'll spend some time in a couple slides talking about what that is, how it relates to dementia, normal aging, things of that nature. And then finally, I've approached this in that early part. You do have some patients that just have the language deficit, and that's the aphasia. Sometimes it can be a expressive aphasia. I can't actually get the words out. Sometimes it's a receptive aphasia. I can speak normally, but I can't understand what you're saying to me. And sometimes it's a global aphasia, meaning that it's both combined. And that's obviously very challenging for a patient or a client that can't understand or express themselves clearly. So some techniques. And the big piece of this here is we want to work together, not in contrast to each other. So when we're working with patients in these special groups, really prioritizing person-centered communication, it can be very daunting sometimes to work with individuals who are different from us. And I think that this goes beyond intellectual disability, this goes beyond Down syndrome. We have this hesitation when we first meet somebody who's new. And I think that really talking at a very basic level and just understanding that you're talking to another human being is a very important thing, something that sometimes doesn't need to be said, but I think that at conferences like this, we've all been in that scenario where we interact with somebody and you just feel uncomfortable at first, but just lowering that down. You're not gonna say anything that is too silly to not engage with another human being here. Focus on the strengths and the preferences. So everybody has preferences, right? Some people drink their coffee black, some people don't like coffee, some people like cheeseburgers, some people like fish. We all have preferences. These are things that we can incorporate into our day-to-day plans as well, and this is a really important thing, especially for individuals who maybe have a little bit more narrow range of things that they like. And this becomes really important. The strengths and weaknesses are also important to acknowledge. As we talked about before, giving a reading task or a writing task to somebody who has dyslexia is going to be really, really challenging. If you have a sing-along or a karaoke, that could be challenging to somebody who has an aphasia or has one of those language predominant issues. So we need to be thinking about what is the type of disability, what is the type of strength or weakness, and how do we incorporate that into our daily care plans. Also, allowing extra time for activities, allowing extra time for processing, and allowing extra time for conversation are really important. Taking that pause sometimes can seem a little unnatural, but taking 2-3 seconds after you say, we're going to do this activity, allows many individuals, especially ones with cognitive or processing delays, that extra moment to give you the response that they want to come out with. This is particularly important for people who have motor issues and have difficulty forming words or have speech-based issues as well. What I usually will recommend is count to 3 in your head, and then we can initiate. But I think that for fast talkers like me and some of you guys, it can be hard to wait that extra couple seconds. Some of the techniques for connecting to are predictability and structured environments. People, regardless of intellectual disability, Down syndrome, or anything, we like to know routine. We like to know what is coming ahead. The reason why Sarah told you what the organization for the day is that we can mentally plan ahead and have a structure. We find that using routines and then being able to mix and match can be really beneficial, especially when every day is a little bit different. This is increasingly getting utilized more and more in care homes, specifically nursing homes, where you can look at the board in the morning and say, oh, today is my activity day where I'm going to do karaoke, or today's dance day. Things that become scheduled and you look forward to it. Even when it comes to other activities like, what are you going to eat, right? Taco Tuesday, who's heard of that? These are things that we all get excited about, right? And so the same thing can be done for activities. And so I'm a big proponent of using visual schedules and step-by-step guides for people as they age, but also just across the board, because it really does help set the expectations for what we're going to be doing. So some of the nonverbal communication is going to be really important for some of our patients and our clients. We need to know when somebody's sad, angry, happy, if they can't tell us that, right? It's easy to say, I'm frustrated. But sometimes we have to think about that on the other end, is if you can't communicate that to me, how do I figure out that you're frustrated? How do I figure out that this task is not going to be, for you? And I think that this is really, a big push to know your clients, know your patients really well, because this is going to be different in every single person. So spend time up front learning what those are. The best tip that I have here, talk to family members, talk to long-term caregivers, talk to the long-term primary care doctors. They may have this information already, so when you're getting settled with a new client, new patient, you can actually learn from that and have a baseline to operate off of. Recognize the interaction between health and behavior. I can't stress this enough. When a client or a patient is not cooperative, when they are saying, I don't want to do something, it may not just be because they're being stubborn. Sometimes it could be because they're stubborn. I know as a stubborn person myself, I get it. But sometimes they may not be feeling well. That may be the first tip-off where you say, Miss Sally is always so happy, so engaged from the moment she gets up. She looks forward to XYZ activity. The last 2 days, she's just stayed in her room and she hasn't wanted to get out or engage with us. That's unusual behavior. The thought process should not be, why is she being so stubborn, right? Because I think we all have our schedules that we have to kind of move forward with. But what may be making her act this way? Pain is a very common issue that people with both intellectual disability and without intellectual disability experience. But if you can't communicate that, right, and we're not maybe having those receptive language cues, we may need to actually do a little bit more of an evaluation of why is this individual acting this way. Sometimes the other thing that we'll see, and I have this on some of our later slides, is that if your things like your thyroid aren't right, if your sodium level is too low, if that medication change that your doctor made last week is making you too sleepy, these are things where we may notice that and it may look like a behavioral issue when in fact it's actually a medical issue underlying what's going on. I think it just went the wrong direction. Oh, there we go. Finally, the autonomy and informed choice. This is something where we want to not just say, this is the schedule, you do it, right? Because that's the easy way. It's just almost like when we were in elementary school, right? Like, here's what we're going to do today, and you don't really have an option. What we want to do is support joint decision making. And individuals that have difficulty making decisions, limit some of the options. Just say, would you rather do A or would you rather do B? Make sure they're obviously good options. One really, really bad, and one obviously good. But for the decision making. I cannot stress this enough for our adult patients with intellectual disability and Down syndrome, because they have preferences. They know what they like. And this is something where when we give the joint decision making, it really allows engagement with our clients and patients, as opposed to just saying, this is how we're going to do things. So let's talk about aging. So the lifespan of individuals with Down syndrome, neurogenetic disorders, and intellectual disability have gone way, way up over the last 50, 60 years. So as you can see down here, in 1950, people with Down syndrome would live to an average of about 12 years. That's crazy. Now, in the 1990s, you hit 40 years. Today, it's 60 plus years, right? These are tremendous leaps. You see the same pattern in some of our other conditions: Fragile X syndrome, Rett syndrome, Angelman syndrome. All ages are increasing over the lifespan. Now, this is really good. This is doctors saying, hey, people with Down syndrome have heart disease when they're born. Let's fix that, right? We started fixing that in the 1980s. Life expectancy shot up into the 90s. We're seeing the tail end of that for a lot of different conditions now, where we have playbooks for the medical care of individuals with special needs, and this is kind of a direct reflection of that. In some places, you can actually have multidisciplinary care teams that help take care of you. Obviously, I'll use Down syndrome as an example because I work with that patient a lot. People with Down syndrome are at risk for a variety of different medical conditions. Now doctors actually have a set of recommendations that come from the Academy of Pediatrics and the National Institutes of Health to say, these are what you should be screening for, this is the age you should be screening for it, and we have had a tremendous benefit from a physical standpoint because of those recommendations, which are now starting to get unrolled in other diseases. But the US has an aging problem. We are getting older. So this little blurb right here, let's see if there we go. This little blurb are people between 50 and 65 years old. We talk about this in the media. We say, oh, all of these boomers, right? How many of us have heard that term before? All of these boomers are getting too old, right? It's going to stress our system. Well, actually, the same thing is happening in individuals with intellectual disability, genetic conditions, and Down syndrome, is that same population is also getting older, and they have even more care needs sometimes. So this is something where it gets lumped in all together, where we say our population in the US is aging, but it's also really important to acknowledge that our special interest populations that we're all together here today talking about are also getting older too, and we're not making adaptations for that yet. So how do we support some of the normal aging as people get older? The first thing is healthy diet. I mean, I wish I had some branded fancy diet. I could say it's the Santoro diet and everybody should try it. But in reality, what this comes down to is that people who are older require less calories. And I think that everybody finds their role of saying, I'm either a calorie counter or I'm not, but I want to eat healthy. But if you think about it, we always recommend knowing that if you are a little bit less mobile, right, and this may be part of the physical disability component, you need less calories than somebody who's active. Men tend to need a little bit more calories intake than our female patients. And the other piece is, as you get older, you need even less. So these are designed for people who are under 70. If you're over 70, those numbers go down even more. So maintaining optimal nutrition is not something that gets talked about a lot, but really evaluating what you're eating, especially if it's in a shared care environment, can be really, really important. I find that there are a variety of good apps that you can actually track, and not to say, okay, well, is this 1 calorie more than the next, but to give you broad strokes. I love Oreos. When I put in how many calories in an Oreo, I shot out of my socks because I was so surprised that there was high calorie content in that specific snack that I really liked. And it allows us to make that transition from, I would normally eat this, but I found that it's actually too high calorie. Now I'm going to eat that instead. Or you know what? Instead of 2 cookies at dinner, we all have sweet tooths, I'm only going to have 1. And it can be really helpful because those little adjustments actually go a long way for maintaining healthy body mass composition as well. Physical activity is really, really important. That's why places like Special Olympics are so great. We want to keep people active. We want to keep people moving. As we age, though, we have to change the types of physical activity that we do. So I think that the best example of this is when we're teenagers or in our 20s, we can do pretty much anything, right? Then as we get older, the aches and pains start to set in. We realize we can't keep up with everybody to the same extent. And that's why we look at low-impact aerobic exercises. This is walking, swimming, cycling, if you're able to, are really beneficial to actually keep your heart rate up and to make sure you have good cardiovascular health. The functional strength training, this can be done without a gym. So this is stuff at a nursing home, at a shared group home, where you can actually have a lot of benefit. Chair squats, where you just quite literally hold the back of a chair and do this, are instrumental to keeping your tone and keeping your muscle mass active. Things like wall push-ups, light free weights, these are things that can be done in a short amount of time, but help keep your muscle mass up, which is actually associated with better health outcomes long term. I'm a big proponent of video games. Maybe this is just me being a millennial and growing up with them, but Wii Fit, dance, yoga, using electronics, to the extent of keeping up physical activity is a great type of integration with that. Obviously, we don't want to have people parked in front of video games and parked in front of the TV, but if it's active and it's engaged, that's a really fun activity and way to do both. And then finally, group-based activities. I know Special Olympics is awesome at this, but bowling, dancing, adapted group sports, these are things that can be very easily integrated without a lot of financial investment either. And those types of activities, just like Taco Tuesdays, are things that people look forward to. So having that as a scheduled time once a week, twice a week can be really beneficial for patients as well. I think maintaining the cognitive engagement is a really challenging task sometimes. And I think that because people have different abilities across the spectrum, we need to be mindful of that. So when you have or host an activity for individuals with intellectual disability, Down syndrome, it may be that you have to have subgroupings of those activities or mix those activities up so that way they're appropriate for people at different cognitive and intellectual capacities. Music and movement are great, but again, as we talked about, karaoke may be challenging for people who can't necessarily sing along. They may like the movement and the music part of it, but again, adapting it to the individual is going to be really important. I'll call out Darcy over here, who has Dining In with Darcy that I participated in yesterday. Cooking is another great way to get people engaged. And again, looking at ways that we can not just adapt and do fun activities, but also have it so that way we can participate in the environments that we're actually a part of. So I think that this slide is really meant to say we can have activities that people are doing at their centers or at their homes, and then there are activities that can actually help the place run. And I think that when we think about how we go to work, right, we just want something that is fulfilling, that we can walk out at the end of the day and say, all right, I really helped out today. And that's exactly what these types of activities can do to keep that mental engagement. Finally, I mean, my wife says if we were not married, I would just live in a dark room all day. She's definitely the creative person in our relationship, but having a nice environment that you can go back to is dramatically important. This has actually been scientifically studied in everything from animals all the way up to human beings. And I think that it's something that we really don't talk about a lot, but having an inviting home environment that has good lighting, safe adaptions, obviously, if you have a physical disability, and incorporation of those personal and family mementos that are really great, especially for people as they get older. It provides a touch point for people when you come into their room, they can say, let me tell you about my niece or my nephew, or this is the picture of the new baby in the family. It allows them to kind of connect, one, to the outside world that may be different from a group home or a nursing home environment, but also allows them to continue to have that engagement beyond just their singular day. And finally, I think that this definitely gets a little bit understated. We need to promote good sleep. I'm a neurologist. We have to talk about sleep, sorry guys. But being able to have consistent bedtimes, consistent rituals and schedules around that are really great. Screen time is not just for kids, we're always talking about screen time, but for adults too. Going to sleep with the TV on causes disrupted sleep in 70% of individuals. This is a really important thing. How many people fall asleep to the TV being on? I do it. I mean, I'm not going to say I'm free of this. It's really disruptive to the pathways for getting into that deep REM sleep that we all want to go for. So as we support normal aging, it's also really important to know when things are not normal. And again, as I talked about in the beginning, this is something where as a caregiver, as a primary liaison, your client, your patient, you may be that first person to say, you know what, this just seems a little bit different. So I've kind of highlighted this over here. This is about the best graph I could find. So you've got your baseline cognitive functioning, your ability to do things. And if we stay up in this fun part, you're going to have the normal cognitive functioning for your baseline. If it starts to drop off, there's this subgroup that is often called mild cognitive impairment, or MCI. This is where things start to look a little bit different, but you're still able to carry on from most of your activities. But it can be the sign, often in hindsight, where like, you know what, for those 6 months, those 12 months, you know, Miss Susie started to act a little bit different, and now she's really different. That might have been the mild cognitive impairment stage, and this is before you get to something like dementia or Alzheimer's disease. So when we get to things that are not right, what we're looking for is, are you having gradual cognitive slowing? Are there changes in your motor function or your coordination? Are there sleep changes? And is there emotional ability or behavioral changes? This is often the 0 to 60. People who are normally cool, calm, and collected and happy, all of a sudden they're getting agitated, they're getting frustrated, they're getting angry at things that they would have never had a problem with before. And I think that some of the caregiver takeaways here are that while forgetfulness is normal, right? We've all forgotten something across the day. When we start to see themes that on a multi-week capacity are starting to be different or become more and more consistent, that's something that that should warrant some extra attention. The loss of ability to do tasks that you previously could, that's a big one. So oftentimes the first thing that we see is it's the helping out tasks. It's emptying the dishwasher, it's setting the table, it's going to fold the socks in the way that you've been doing it for 50 years. All of a sudden, it starts to look different. My grandmother had Alzheimer's disease. She was a phenomenal Italian old school cook. She started burning stuff. And there was no memory issues. Like, she remembered everything, she was speaking normally. She started overcooking the meals. And so my grandfather, who was a grumpy old Italian man, would say, Josephine, what's going on over here, right? There was a big problem in the house. But that, in hindsight, was that first piece where it was something that she had done so exquisitely at a high level for many years, suddenly started to change. And I think that that's what we're really looking at for those adapted abilities that they've been doing for a long time. The sleep issues, again, neurologists up here, you're going to get a little bias on this. Sleep issues are really important. You get restlessness. You start acting out of your dreams. This is something where, I mean, you could probably go on YouTube and find many clips of this. People are just, you know, screaming and thrashing in their bed. This is something called a REM behavior disorder, where we go into our dream sleep during REM sleep, or that deep sleep. And normally our body gets paralyzed. I don't know if you've ever seen anyone who does the eye movements when they close their eyes. They can kind of see it right under their eyelid. That's what REM sleep is, but the body normally paralyzes you just for a short period of time, and then you kind of come out of it. But when you remember a dream, it's because you just woke up out of that REM sleep. In the brain, though, when there's other neurologic problem going on, a dementia process, even Parkinson's disease, that paralysis part goes away. And so suddenly you start acting out what you're seeing or what you're experiencing in the dreams, and it looks like, oh, they're just having a nightmare. But right, in a person who's never had a history of this and they start doing it, it's another tip-off that something may be different. When we look at Alzheimer's disease, obviously it is very highly prevalent in people with Down syndrome because of their genetic difference, but this can happen to everybody. The key here is that if you have a neurogenetic condition, if you have Down syndrome, Rett syndrome, autism spectrum disorder, if you develop Alzheimer's disease or dementia, it is going to happen earlier and it's going to progress faster than individuals who don't have those issues. So while this isn't a rapid sequence where everything is falling off, over a period of weeks, this is something where it may be really striking, often when you have a family member visit who comes from far away, and they'll say, hey, Miss Smith or Auntie looks different. What is going on? She used to be able to do all of these things. Now she's not doing any of it. On a day-to-day basis, it can be hard for us to pick up those things. The best way that I think about this is when you kind of look at pictures of your children or your loved ones' children's, and then you're like, I can't believe how old they are, right? Because you see them so frequently. But then when you make that transition, you haven't seen someone in a very long time, it's often quite obvious. I see this in my own clinic, where we see patients maybe once every 6 months, and I can say, wow, they look a lot better or they look a lot worse, because I'm not seeing them every day as they slowly move down or move up in their functioning. This is a very detailed slide, but something that I wanted to highlight here is that although the onset of Alzheimer's disease, and this is specific to Down syndrome but could be applied to other conditions as well, although the symptoms start much later, this process in the brain starts very early, almost 20 years prior to the development of the symptoms. This is why we're investigating from a research standpoint, are there differences in people with autism, intellectual disability, Down syndrome, where we may have a targetable option that helps prevent this or push this whole process back in later years? This is one more plug to be involved with research. So involving yourself in these research studies where we're looking at things like biomarkers may help us say someday to a drug company, hey, we want to use that FDA-approved drug therapy for Alzheimer's disease, not at 50 when the symptoms have already started. We want to use it at 20 when this process starts up over here. So one more plug for research. Obviously, I do a lot of it, and I'm very biased for it, but I think that that's why we're constantly asking people who have Down syndrome, intellectual disability, and autism to engage in research so we can help apply some of those new advances in other populations to people with these special needs as well. Just to go back to some of the other symptoms that you're going to be looking for, right? The forgetfulness, the motor function. You don't want to see falls. I know in care home environments, shared environments, right? Falls are the big no-no. But if you're finding that your patient who has been very steady on their feet is all of a sudden falling, they're having unsteadiness, or they're looking slower in their movements, these are things that you can say, all right, this is different and we need to get some attention for this. We talked about sleep, and again, that emotional ability and behavioral changes. Obviously, if you're seeing delusions or hallucinations, that's the fast track to getting evaluated very quick. Delusions, and I'll just talk about this very briefly because it can happen in people who have the early signs of mild cognitive impairment. A delusion is when you think something is happening that it's not. So this often is accusatory. So-and-so is after me. They're trying to mess up my meal, or they're trying to kick me out of my room, or they're trying to do X, Y, Z. Sometimes it's targeted, sometimes it's not. But if you start to see that type of delusion where people are suddenly against an individual, that can also be a very early and subtle sign that something may be going on from a cognitive impairment standpoint. The mimics, right? So this is something that most of the caregivers at this conference are not going to have to do, but this is what we as doctors are often looking at. Is there thyroid or metabolic dysfunction that could mimic this? If your thyroid is off, you could look as though you had dementia, right? And this is an easy, fixable thing that only takes a blood test to figure out. Depression can also mimic dementia. So in individuals with intellectual disability or Down syndrome, we call it pseudo-dementia, where you're depressed because something happened, but then the symptoms of it are not crying and being upset. It's actually looking very sullen, being extra forgetful, not wanting to leave your room, being slow of movement. Hearing and vision changes. This seems so easy, but hearing and vision for everybody gets worse as you age. If you're suddenly unable to hear others talking, are you going to be talking to them? Right? No. So it's one of those things where the initial report may be, Mr. Smith is talking less. He just seems so down. I wonder if he's developing dementia. It may be that his hearing aids aren't on, or it may be that he needs a new adjustment to actually hear better so he can engage with the world around him. Insomnia and sleep changes can also be idiopathic as well, so it may not be a secondary effect of a dementia process, it may be the actual cause. So don't forget, when we talk about obstructive sleep apnea, why do we care so much about it? That snoring, that you develop at night, that is actually waking you up. You are not cognitively awake for it, but your brain goes back on and then it turns off again. So you're getting interrupted sleep. You never make it into the deep, restful sleep that we need to go about during the day. That can also mimic a lot of these symptoms. There are certain populations that are extra at risk for this, Down syndrome being one of them, just because of the facial features that go with it. But other conditions like Rett syndrome also will have that. So if your client hasn't been evaluated for this, it may be a cause that is actually very easily reversible with using a CPAP. There can be cardiac issues, pain, and some of the other neurologic symptom or conditions that I'll go into in just a moment as well. But the key here is you may have to be the primary evaluator, the primary person that signals the alarm that says something is different here. So you can request an evaluation by a primary care doctor, or if they're not available, somebody who's known your client or your patient for a very long time. You can go to a family medicine doctor, internal medicine doctor, or a geriatrician. And then after those initial evaluations, sometimes they'll refer out to a specialist who may be a neurologist, geriatrician, or a psychiatrist as well. Here's my tips though. As a caregiver, you also need to be prepared, right? Because that patient may go to the doctor's office. That doctor may have 20 minutes. All right, what's going on? How many of us have heard that before from the doctor? Tell me what you're here for, right? And it's tough because oftentimes we get into those environments and we have to just spit out, right? We all get nervous. We just kind of spit out a bunch of random stuff. Be organized. Be prepared. Write out what you've been seeing so you can almost read off the script or use it if you need it. Give the timeline when things are occurring. One of the things that doctors are listening for is how fast is this happening, right? And that is actually one of the triggers for them to say, I need to do something, or this just seems normal. Provide images or video if you're able to. Sometimes if it's an unusual movement, I think that that's often a lot easier to capture. So for instance, if we're kind of using that earlier example of cerebral palsy, Mr. Smith is getting more and more stiff. Here's a picture of him from 6 months ago where he's a little bit less stiff, and here's a picture of him last week where he's very tight. That can be really beneficial for the doctors and the evaluators to say, all right, this is clearly different. I trust what you're saying. And it's okay to let the doctor know that you have a specific concern. You can say, I'm worried about dementia, or I'm worried about this developmental regression, or you know what, that movement I saw, it looked like a seizure to me. You don't have to be a medical expert, but it helps guide what your concern is to the doctor, to the medical team as well. So as people with genetic conditions, intellectual disability, autism, Down syndrome get older, there are some other neurological issues that we want to be aware of. So when we look at epilepsy or seizures, people with these conditions are at 10 times the risk to develop epilepsy. Now, seizures can look like many different things. Oftentimes it's going to be the classic eyes roll back, people have jerking of the arms, like almost like what we've all seen on TV. But sometimes they can be very subtle. They can be myoclonic jerks that tend to cluster all together, that don't seem to be under that individual's control. Sometimes they can be head drops. Head drops look like this. You're talking to somebody and they go, and they pick it back up. That could be a seizure, right? Unusual behaviors that you don't have an explanation for that are quick should be concerning for seizures. They can be anything, right? And we're not going to spend a ton of time going through all the different hundreds of seizure types, but if it's short, if it's uncontrolled, and it doesn't seem to be triggered, so the same thing happens and then this person always has an event, those are signs and symptoms that we would want to get evaluated for seizure. Cerebrovascular disease and stroke are 2 to 3 times a greater risk. Now, thankfully, if there is a thankful in this increased risk, the symptoms are the same for everybody. It's going to be weakness on one side of the body. All of a sudden, that one side is just a little bit loose, and now you're starting to drag your feet, you're unable to lose your hand, or you have drooping of the face on one side. Often, if you have an individual that is able to communicate verbally, they will also have slurring of their speech as well. Myelopathy or spinal cord compression is 10 times greater risk as well. The symptoms of this are going to be gait issues. So this is a compression in the spinal cord as the bones get weaker and start to press on the spinal cord. Usually this is going to be incontinence. It's going to be hand clumsiness if it's high enough up, and it's going to be inability to walk. So this can be painful, and it's going to cause a weakness in the lower extremities. This is an individual where you say, Mr. Smith hasn't wanted to walk for the past 2 weeks, and he's also urinating on himself. This is all new stuff. This is usually going to be acute onset, very similar to stroke, but a different mechanism. Peripheral neuropathy, this is often what we talk about with patients who have diabetes. There is a lot of comorbid diabetes in these populations as well, but this is going to be numbness. Sometimes it can be burning in the hands or the feet, and often because you're not getting that sensory feedback from the legs, people can also start falling in this as well. And the last, as we just talked about, sleep apnea is 30 times the risk. This is the biggest risk in this population that is something that is so easy to diagnose and so easy to treat, so always have it on the back of your mind as you're thinking about things as well. So as we talk about this accelerating aging, I want to highlight that this is not just for people with Down syndrome. This is not just for people with intellectual disability, autism spectrum disorder. Many other neurogenetic conditions, many other neurologic conditions also have this more rapid movement to the accelerated aging of the brain and also the development of these other neurologic conditions. So when you go seek medical care or medical evaluation, a neurologist or even family practice internal medicine doctor is going to be able to say, all right, I know that this individual population is at this greater risk for these complications. I'm going to focus on testing of this specific set that I know that they're at greater risk for. From the caregiver side of things, have a plan. I can't stress this enough. If you have an individual that has epilepsy, this is an example of a seizure action plan. Be comfortable with what it is, be comfortable with what the game plan as developed by the doctor or the medical team is, and then if you're uncomfortable with executing that plan, ask for additional training, because you may be the person that has to administer the emergency medication. You may be the person that says, all right, this is the plan that we go to the ED or the emergency room for these symptoms. So know it, have it available, and then ask for the training too if you feel uncomfortable with that. So the big summary here, working with individuals with Down syndrome, intellectual disability, and autism is awesome. It's the highlight of my life. I'm sure it's the highlight of many people's life in this room. The big key here is be yourself, be knowledgeable, and be prepared. Be prepared when you're saying, I'm worried about this, or here's my action plan for this other combination of symptoms, and that's going to be the best way that we can service our clients, our patients, and the community at large. So with that, I'm happy to answer any questions. Hopefully I left a little bit of time for everybody to ask some. So thank you. I think Joe's got a question back there.
Your speech is right. Everything what you're speaking about, it's at the Pioneer Home, and I brought the head of the Pioneer Home in charge of all 7 Pioneer homes in Alaska. He's here because I wanted to show him what this means to us, because I had somebody came, I didn't know he had that kind of thing. He came, I was covering upstairs, and he came over and punched me. That's why I got this thing. And it's all simmering, and he didn't know what he was doing. And I'm trying to get more professional things, because I brought everything you talk about. We got a news thing, and it tells you what we are doing at the Pioneer Home, and it gives you a story about everything about Pioneer Home. That's one. I got another one. This is telling you our activities. Ice cream social every Friday, except it's Thursday. It gives you, we're going shopping today, and everybody's at Fred Meyer's at 8:15. So this is that, and the menu is underneath this. And so people like these activities, and that's what I'm here for, is find out how could we get you to come and teach these people at the Pioneer Home, professional people, how to handle these people, because I see the same thing, seizures, people need more help, people are out of control, and I see it all the time. I am a pioneer, and this is what the Disability Summit is about.
Well, thank you, Joe, for that comment. I mean, it really highlights the importance of this stuff, right? Every person is unique, right? And I think that finding things that are one size fits all is not the best approach. But a perfect example, right? The schedule. It's something to look forward to when you've got your activities listed. But I also think on the other end is that home environments, just like the Pioneer Home, are not great because there's not a doctor there, right? It's not a clinic. So having that interaction with the medical team where you can have those plans set up in advance, that you say, all right, my client, my patient may have an anger issue because they're dealing with the early signs of dementia or mild cognitive impairment. These are the medications that this individual is going to use, and when it gets out of control, this is the plan for it. So that way, all of the staff that are there can be on the same page, because otherwise things can continue and be problematic. But I think you're highlighting a very important point. A question right up front. So I don't have a website that addresses this sort of stuff, but the Children's Hospital Los Angeles, and we have a Down syndrome program website. It talks a lot about some of the more common medical issues in that community, but this is something where we could even partner with the folks up in Alaska to develop kind of joint resources. And sometimes the states are really good with that, but I think getting everybody on the same table with Special Olympics, the state, and the medical care providers are really important. So that's great to see that there are so many of those representatives here today. Got another question.
Thank you. My question centers on a connection with hearing loss and dementia. I've recently thought I heard that there was it's either a mimic, so people who are experiencing hearing loss may just be presenting as if they're having dementia, or do we know there's an actual link between hearing loss as people age and even more onset of dementia, more so than it already exists?
It's a really important question. So they don't have to be mutually exclusive. So as we age, all of our hearing gets worse and worse, and that's normal. So as we age and are at risk for dementia, you can have appropriately graduated down trending of your hearing organically. However, if you're saying, all right, Mr. Smith is acting differently, I'm worried that he might actually have dementia, hearing testing is part of it, because that's something that is so easily correctable. Now, sometimes we've had cases where an individual's hearing aids, just the batteries haven't been replaced. They're putting them in every day, but they stopped working a couple weeks ago. Totally easy. Those are the cases where we already know that there's a hearing problem. The other cases, though, when we haven't tested it, right? They come to a group home environment, and we don't know what their hearing history is. It's an easy test. It takes about 10, 15 minutes, and you can actually gain very valuable information from it. So I wouldn't say that they're mutually exclusive, but if you have a patient, even if they have dementia already, and they seem to be getting worse, repeating the hearing testing is very easy and something that could actually go a long way for keeping functional status elevated. Great question.
I was going to quickly jump in from over here about that first question over there about the resources for like the website or anything like that. Special Olympics has a table in the back. I'm the inclusive health manager here at Special Olympics Alaska, and we print out like paperwork on what you should fill out before you go to a doctor's appointment. Like there's one where it's like about me, and so it's all of your like what your diagnosis is, if you have any like sensory issues or anything like that, but then also your concerns, and it's all written out on a paper. So literally all you have to do, if anything, is hand it to the doctor, and it has everything on there. Another place to look is Surrey Place in Toronto. They do a lot of work for primary care. It is through a Canadian like medical system, and so it's a little different than the American medical system, but they still have a ton of checklists for if you're going to a doctor's appointment, what kind of symptoms you should write down on the paperwork or anything like that. So that's the Surrey Place. It's SURRY. I go on there all the time to help our athletes with appointments and like scheduling appointments and things like that. And so if you are looking for paperwork on just kind of checklists or the kind of things and how to talk to doctors, that's definitely a place to look at. I also had another question for you. You talked about getting people with intellectual disabilities involved in research. How does one find opportunities to be a part of research? Is that something that the doctor would tell them about when they're in an appointment, or do they have to go out and like look on the NIH or something like that?
Yeah, so it's a great question. So it's a little bit of A, a little bit of B. So sometimes the doctors may say, hey, we have this research study that you're eligible for. Would you want to participate? So at our center, right, we do a lot of research. So almost all of the patients that come to see me, I'm constantly saying, hey, there's this study on Alzheimer's disease. There's this study on stroke. There's this study on regression. Would you like to participate? And you're already there anyway. And so we try to make the barriers to engagement very low. In places where there's not an active, two Canadian families, Massachusetts, Florida, Virginia. So you can actually engage in research with a relatively minimal cost. Some of the non-clinical trial studies may be harder. They may not be able to cover some of that, but always search online. The other way to do it, and I think this is a great opportunity for Special Olympics, is to say, hey, we have this list of studies that are ongoing locally. These are the ones that you can engage with, and they're just around the block, or they're in your area of Alaska. And I think that's got another great opportunity as well. But definitely search out those opportunities if you're interested in them.
I have a question. You had said something or on your slide about a seizure action plan. Working in where I work, there's quite a few of people that have seizures. Where do you get the information? Is it just just searching the web?
Yeah, so the American Epilepsy Foundation has excellent resources for that. So they have little PDF printouts that you can do for seizure action plans, which are really beneficial. It just takes down the stress level so much when on that form that would be in the room of a client or a patient, it says, this is what the seizure looks like, this is how long it lasts for, these are the medications that the client or the patient is on, and this is what to do if they go over 5 minutes, or this is what to do if there's more than 3 in an hour. So that way, everybody who walks in the room, even if it's the first time you're meeting them, they can reference that sheet and know exactly what's going on in 30 seconds.
I just had a quick question about, are you developing or working on any new research, or at the center is working on any research with, I had it written down here, like molecular factors evolving around like mental illness that also, between gene and brain development?
Yes, so this is one of our passion areas. So our primary focus at our center is on Down syndrome regression disorder. So this is a condition that affects people with Down syndrome, age 10 to 30 for the most part, where all of a sudden, over the period of days to weeks, they have a neuropsychiatric regression. It could look very similar to schizophrenia. What we found is that in people with Down syndrome, that may be inflammatory, and those patients are now responding to immune modulation because we've gone down and looked at those molecular mechanisms. Now, obviously, this is very specific to Down syndrome, but it's allowed us to rethink, hey, maybe epilepsy in Down syndrome could also have an immune signature, maybe cerebrovascular disease too, and it's partnering up with psychiatrists, even locally, who are looking at these things in a different way, right? I think a lot of the time we say, this is what we know about psychiatric disease, this is what we know about stroke, epilepsy, whatever it may be, but I think that we're finding more and more information, and we're really trying to push the limits of what we know now using these kind of cheaper multi-omic and basic science techniques. So I think in the next 5 to 10 years, we're going to be rethinking a lot of what we already know about these conditions.
Good morning. My name is Jonathan Strong. Thank you, Dr. Santoro, for coming in today. I'm a caregiver for people with intellectual and developmental disabilities in Kodiak, Alaska, which is a remote island. And you mentioned last night that at the event you had here that your hospital doesn't do telehealth but I'm working with a family, and there's a barrier to receive services in Alaska is a neuropsychological assessment. Mm-hmm. And right now, it's 7-8 months potentially for somebody to get that assessment. And if you're on a remote island in Kodiak and you have challenges with flying and traveling, what are your thoughts on neuropsychological assessments being done via telehealth?
Yeah, it's a great question. And I will say 7 to 8 months isn't even that bad. I think we're at a year in Los Angeles right now. there's a huge demand for neuropsychological testing because it's valuable in people with autism, intellectual disabilities, cognitive impairment, MCI, Alzheimer's disease, right? Like everybody could benefit from a neuropsych testing. We do about 30% of ours are at our center as telehealth. It's not the same, and you need somebody to assist on the other end, on the receiving end. That may be a caregiver, that may be a parent, but to have somebody who can help administer the test makes it a little bit more reproducible and doable. The big barrier, though, is the individual who's on the receiving end, who's helping out, needs to familiarize themselves with the testing modality. So basically, we usually suggest so distributed may be a necessity as well.
I was just going to see if you could talk a little bit about dementia, like baseline testing that care providers could do or staff can do. I know that recently they've created dementia testing for people with intellectual disabilities, and that it's so important to have a baseline. I don't know if you're able to talk a little bit about that.
Yeah, so the good news is there's a lot of new screening measures that can be done quickly in the clinic. And so I think that if you're coming in and have a concern for that, you can even ask when you're scheduling the appointment to say, we're bringing in Mr. Smith because we're worried that he may be starting to exhibit signs of dementia. Do you have screening testing that you could do at that visit? Just prompt the folks behind the desk, because all they have to do is print out the screening measures. If your client, if your patient has intellectual disability, Down syndrome, there are specific other screeners that may be available for those populations. All of them are online. So, I mean, you could even print them out, do a PDF and print it out and bring it to the visit as well. Obviously, they usually like to administer it in the clinic as well. But just let them know when you're scheduling the test, because all it requires is the MA or the medical assistant to make a note of it and put it in the file and hand it to you when you come in the door. It's very quick. Now, the neuropsychological testing is a lot different. That's a scheduled event, takes a little bit more time, but plenty of screening measures. All right, guys, did I talk everybody's ears off? Connecting with all of you.